Local anesthesia forms the backbone of pain control techniques in dentistry. Deposit a local anesthetic drug near a nerve, and clinically adequate pain control will result in essentially all clinical situations. Local anesthetics are the safest and the most effective drugs in all of medicine for the prevention and the management of pain. Indeed, there are no other drugs that truly prevent pain. No other drugs actually prevent the nociceptive impulse from reaching the brain, where it would otherwise be interpreted as pain by the patient. Local anesthetics produce a transient and completely reversible state of anesthesia. Since all injectable local anesthetics are eventually absorbed from their site of administration into the cardiovascular system, they must possess low systemic toxicity. The injectable local anesthetics undergo detoxification in the liver and are excreted through the GI tract and the kidneys. In this program, we will look at the drugs, the armamentarium, the techniques, and the complications of local anesthetic administration in dentistry. Many dental procedures are potentially painful. If the nerve impulse reaches the patient's brain, it's interpreted as being painful. How does the nerve conduct this impulse to the brain, and how do local anesthetics act to prevent this from happening? Sensory neurons that conduct pain are composed of three major parts: the axon, the dendrite, and the cell body. The single nerve fiber, or the axon, is a long cylinder of axoplasm which is encased in a thin sheath, the nerve membrane, which separates the axoplasm from the extracellular fluids. In some nerves, this membrane itself is covered by an insulating lipid-rich layer of myelin. There are constrictions along the myelin called nodes of Ranvier. At these nodes, the nerve membrane is exposed directly to the extracellular fluid. At rest, there are differences in the concentrations of ions found inside and outside the nerve. The inside of the neuron is relatively negatively charged compared to the outside of the nerve. When stimulated, sodium channels open, permitting the rapid influx of sodium ions into the interior of the nerve cell. The interior of the cell becomes positively charged as these sodium ions rapidly enter into the cell, a process we call depolarization. Then the process of repolarization starts, with the active transport of potassium ions out of the nerve cell to restore the resting equilibrium. In non-myelinated nerves, the impulse moves forward by a sequential depolarization of short adjoining membrane segments. In myelinated nerves, the impulse leaps forward from node of Ranvier to node of Ranvier, a much more rapid conducting process called saltatory conduction. The propagated nerve impulse reaches the brain, where it is interpreted by the patient as pain. How do local anesthetics act to prevent the nerve impulse from reaching the brain? Locals act by blocking sodium channels, so that when the nerve is stimulated, sodium ions cannot enter into the cell, thereby preventing depolarization. The local anesthetic is deposited as close as possible to the nerve and by diffusion enters into the nerve. Local anesthetic outside the nerve diffuses into an uncharged and a charged ionic form. It is only the uncharged form that is lipid-soluble and is able to diffuse through the nerve membrane and into the nerve cell. Outside the nerve, only charged ions remain, and some redissociate into uncharged ions which can then enter into the nerve. Theoretically, all the charged ions eventually become uncharged, but because there are lymphatics and blood vessels in the surrounding tissues, a quantity of local anesthetic will never enter into the nerve. On the inner surface of the nerve, some of the uncharged ions redissociate into the charged form. These charged ions enter into sodium channels attaching to drug receptor sites, blocking the entry of sodium into the nerve when it is stimulated. This prevents the propagation of the nerve impulse. The impulse does not reach the brain, and pain does not occur. When enough local anesthetic is diffused into the nerve, impulse conduction is stopped and the patient is anesthetized. How do local anesthetics stop working? Eventually, an equilibrium occurs between the amount of anesthetic inside and outside the nerve. As the anesthetic outside the nerve continues to diffuse away from the nerve in blood vessels and lymphatics, the concentration gradient changes, with less anesthetic outside than inside, and the local anesthetic begins to diffuse out of the nerve. Eventually, there is not enough local anesthetic left within the nerve to adequately block nerve conduction, and the patient slowly begins to feel again. This process is termed redistribution. The local anesthetic is still in the patient's body as an active drug, but is simply not in the nerve in a high enough concentration to fully block nerve conduction. All local anesthetics, except cocaine, are vasodilators. Plain local anesthetics are absorbed from the injection site rapidly, providing the following: a poor depth of anesthesia, a short duration of anesthesia, and higher anesthetic blood levels. Vasoconstrictors, primarily epinephrine, are vasoactive drugs which decrease the volume of blood flowing through the injection site. This leads to the following positive actions: a slower absorption of both the local anesthetic and epinephrine into the cardiovascular system, resulting in lower anesthetic blood levels, longer durations of anesthesia, and more profound anesthesia. What local anesthetics are currently available in North America? At present, there are 5 drugs available. These are articaine, bupivacaine, lidocaine, bupivacaine, and prilocaine. What are the expected durations of anesthesia with these drugs? We can divide these anesthetic drugs into 3 categories based upon the expected duration of pulpal anesthesia. 3 categories are short-acting drugs, providing anesthesia lasting for approximately 30 minutes, intermediate-acting drugs, providing anesthesia lasting up to 1 hour, and long-acting drugs, providing pulpal anesthesia lasting 90 minutes or longer. According to the ADA Survey of Dental Practice in 1999, the typical treatment time for a general dentistry patient is 47 minutes. Treatment time for a specialist patient is 39 minutes. Short-acting local anesthetics provide pulpal anesthesia lasting for approximately 30 minutes. The one drug in this category is bupivacaine 3%. This drug provides pulpal anesthesia lasting from between 20 to 40 minutes and soft tissue anesthesia lasting anywhere from 2 to 3 hours. Long-acting local anesthetics are drugs which provide pulpal anesthesia lasting from 90 minutes up to 3 hours, and soft tissue anesthesia lasting anywhere from 3 hours as long as 12 hours. The one drug in this category today is bupivacaine 0.5% with epinephrine in a 1 to 200,000 concentration. Bupivacaine has a slow onset of anesthesia, approximately 6 to 10 minutes, but provides pulpal anesthesia lasting up to 3 hours and soft tissue anesthesia lasting as long as 12 hours. It is commonly used as a post-surgical pain control medication. Intermediate-acting local anesthetics provide pulpal anesthesia lasting for approximately 60 minutes, and usually soft tissue anesthesia lasting from 3 to 5 hours. In this category, we have articaine. Articaine is a 4% local anesthetic containing epinephrine in either a 1 to 100 or 1 in 200,000 concentration. The 1 to 100,000 concentration is available both in Canada and the United States. At this time, Articaine in a 1 in 200,000 concentration is not available in the United States. Articaine has an onset of anesthesia of approximately 2 to 3 minutes and a duration of pulpal anesthesia lasting for approximately 1 hour, soft tissue anesthesia for approximately 3 to 5 hours. Lidocaine is available as a 2% concentration with epinephrine in a 1 in 50,000 or 1 in 100,000 concentration. Its onset of anesthesia is 3 to 5 minutes with a duration of pulpal anesthesia of 1 hour and soft tissue anesthesia lasting from 3 to 5 hours. Mepivacaine 2% with levonorepinephrine in a 1 in 20,000 concentration has an onset of anesthesia of approximately 3 to 5 minutes with a duration of pulpal anesthesia lasting for 1 hour with soft tissue anesthesia for approximately 3 to 5 hours. With epinephrine, prilocaine provides pulpal anesthesia within 3 to 5 minutes with a duration of approximately 60 to 90 minutes and soft tissue anesthesia lasting anywhere from 3 to 8 hours. Prilocaine plain is interesting. If administered by nerve block, prilocaine plain provides pulpal anesthesia lasting anywhere from 40 minutes to 1 hour. However, if you infiltrate with prilocaine plain, pulpal anesthesia lasts only 10 to 15 minutes. Why don't patients always demonstrate the expected duration of anesthesia from these drugs? Many factors work to modify patient response to medications, including normal variation from patient to patient, the accuracy of our injection technique, status of the tissue at the injection site, anatomical variation, and the type of injection administered. One factor is a normal variation in response to drugs from patient to patient. This is called the normal distribution curve or the bell-shaped curve. The bell-shaped curve illustrates that 70% of patients respond to a drug appropriately. For example, with lidocaine with epinephrine, 70 out of 100 patients will have pulpal anesthesia lasting for approximately 1 hour. 15% of the population are hyper-responders to a drug. With lidocaine with epinephrine, the duration of pulpal anesthesia for these patients will be in excess of 1 hour. It might be an hour and 15 minutes, it might even be an hour and 30 minutes. The last 15% are hypo-responders, persons in whom the average dose of a drug does not provide the desired clinical effect. For lidocaine with epinephrine, these patients may have pulpal anesthesia lasting for only 45 minutes, 30 minutes, or in some cases as short as 15 minutes. This is normal and to be expected whenever drugs are administered. What are the maximum recommended dosages of local anesthetics? MRDs, for the commonly used local anesthetics in dentistry, are calculated as milligrams per pound or milligrams per kilogram of body weight, up to an absolute maximum dosage. Other factors which might modify the MRD include the duration of time over which the drug is to be administered and the physical status of the patient. What factors are considered when selecting a local anesthetic for use in a dental patient? The primary factor is the expected duration of the planned dental treatment.
Every appointment will be no longer than 30 minutes. Okay?
Great.
Then you can go back to business. All right?
Once the drug is selected, then we have to consider if there are any medical contraindications to the use of this drug. The third factor is the need for hemostasis. Are we doing a procedure in which bleeding is going to be significant? If it is, then a vasoconstrictor like epinephrine must be included in the anesthetic drug.
Tell me, Clint, do you bleed easily?
Well, I do get a lot of bruises.
You get a lot of bruises?
Yeah.
Okay.
What is the armamentarium for local anesthetic injections? The basic armamentarium for all local anesthetic injections includes the following: the syringe, the needle, the cartridge, and additional items such as applicator sticks, sterile gauze wipes, topical anesthetic, and a hemostat. What is found in local anesthetic cartridges? Local anesthetic cartridges in North America contain 1.8 ml of solution. According to ADA requirements, as of 2003, all cartridges sold in the USA are color-coded, so their content may be easily identified. A cartridge of a plain drug contains the following: the local anesthetic drug, sterile water, and sodium chloride. In addition, the following are found in cartridges which contain a vasoconstrictor: epinephrine and sodium bisulfite. The shelf life of a plain local anesthetic cartridge is 36 months. If it contains epinephrine, its shelf life is only 18 months. What needles are available for use in dentistry? The following needle gauges are available: 25 gauge short and long, 27 gauge short and long, 30 gauge short and ultra short. The typical short dental needle is about 20 millimeters in length from its tip to the hub. The typical long dental needle is about 32 millimeters in length. The ultra short needle is 10 millimeters in length. A very basic rule regarding insertion of needles into soft tissue is that you never insert a needle all the way into the tissue to its hub, unless it is absolutely essential for the success of the injection. The recommended needles for dental injections are the 25 gauge long and the 27 gauge short. Use of these needles will ensure that the aspiration of blood is both possible and reliable, that breakage of needles is extremely unlikely, and that patient comfort is maximized. How do you aspirate? Gentle retraction of the thumb ring of the syringe pulls into the needle any fluid, air, or tissue immediately surrounding the tip of the needle. A positive aspiration occurs when blood is seen in the syringe. To ensure a true negative aspiration, it should be performed twice, rotating your needle 45 degrees between aspirations. Here is the proper preparation of the syringe. Retract the piston, insert the cartridge, engage the harpoon with gentle finger pressure. Attach the needle. Remove the cap and expel a few drops of anesthetic to ensure its proper flow. Recap the needle. The syringe is ready for use. To disassemble the syringe, retract the piston and remove the used cartridge. Unscrew the needle and dispose of both in a sharps container. What is the proper technique of inserting a second cartridge for additional injections? Unscrew the needle, remove the empty cartridge, insert a new cartridge, embed the harpoon using gentle finger pressure, reattach the needle. How is the patient properly prepared for local anesthetic injection? Prior to administering a local anesthetic, the patient must be evaluated for their ability to safely tolerate the stresses both psychological and physiological, involved in the planned dental treatment. The steps involved include a medical history questionnaire, a physical examination which includes vital signs such as the blood pressure, the heart rate and rhythm, and respiratory rate. We will then determine the patient's medical risk and any necessary treatment modifications. The ASA Physical Status Classification System helps us to determine medical risk during dental treatment. An ASA-1 is defined as a normal, healthy patient. ASA-2, a person with a mild systemic disease. ASA-3, a more severe systemic disease which limits activity but is not incapacitating. ASA-4 is an incapacitating systemic disease that represents a constant threat to the patient's life. ASA 1, 2, and 3 patients are candidates for elective dental care. The use of local anesthetics with or without vasoconstrictors is indicated. ASA 4, 5, and 6 patients are not candidates for elective dental care.
So if you had a history of high blood pressure? Okay. Well, you're running a little high today. And how about your sugar?
Well, it's about 300 something in that neighborhood.
300. You know, you have some serious dental problems, but the best thing for you to do is see your physician. Get everything medically controlled before we do any work on you.
Consideration for decreasing stress to the patient during dental treatment minimizes the risk of an acute medical emergency arising. Steps to be considered include the following: sedation the evening before or the morning of the planned dental treatment, intraoperative sedation, effective pain control during their treatment, a morning appointment, time factor. The appointment length should not exceed the patient's tolerance.
Now, we're going to have 4 appointments. I've decided because of your apprehension, we're going to have short appointments. Every appointment will be no longer than 30 minutes.
Hot, humid weather. The consideration for post-operative prescriptions if needed. Post-operative telephone call the evening following dental treatment.
Hello?
Hi, Julie. This is Linda at Dr. Stan's office, and the doctor asked me to call you and see how you're doing today.
Oh, just fine. Thank you. And please tell Dr. Stan I appreciate his consideration.
I'll let the doctor know. Thank you.
Bye.
What are the steps in the safe and painless administration of local anesthesia? Use a sterilized sharp needle. Check the flow of the anesthetic solution. Determine whether to warm the cartridge or the syringe. Position the patient properly. Dry the soft tissue at the site of injection. Apply topical anesthetic to the site of needle penetration. Communicate with your patient.
I'm putting on some topical to make it more comfortable for you.
A firm hand rest is necessary to stabilize the syringe. The hand rest will vary from doctor to doctor. Persons with longer fingers can use finger rest on the patient's face for many injections, while those with shorter fingers may need to use elbow rests. Any finger or hand rest that stabilizes the syringe without increasing the risk of injury to the patient is acceptable. The tissues at the site of needle penetration should be stretched before the insertion of the needle, making the insertion of the needle more comfortable for the patient. Keep the syringe out of the patient's line of sight. Insert the needle into the tissue and watch and communicate with your patient.
I don't expect you to feel this.
Slowly advance the needle towards the target. Deposit several drops of local anesthetic before touching the periosteum. Aspirate. Slowly deposit the local anesthetic solution and communicate with your patient.
I'm doing this slowly so that it's more comfortable. but I'm not going to give you any more than you need.
Slowly withdraw the syringe, cap the needle, and discard. To disassemble the syringe, retract the piston and remove the used cartridge. Unscrew the needle and dispose of both in a sharps container. Observe the patient after the injection.
Okay, I'm going to sit you up now. Is that comfortable?
Yes.
All right.
Record the injection on the patient's chart. The fifth cranial nerve, the trigeminal, is almost exclusively responsible for the sensory innervation in the oral cavity. The first division, the ophthalmic, is entirely sensory and is of little importance in dentistry. The second division, the maxillary, is also entirely sensory and is responsible for sensory innervation to the maxillary teeth and their supporting soft and hard tissues. The maxillary division also provides sensory anesthesia to the soft and hard tissues of the palate. The third division, the mandibular, is both sensory and motor to the muscles of mastication and is responsible for the sensory innervation to the mandibular teeth and their supporting soft and hard tissues. What are the injections used to anesthetize the maxillary teeth, soft and hard tissues? We will now discuss the following injections which provide anesthesia to the maxillary teeth, their supporting hard and soft structures. Infiltration or supraperiosteal injection, posterior superior alveolar nerve block, middle superior alveolar nerve block, anterior superior alveolar nerve block, also known as the infraorbital injection, greater palatine nerve block, nasopalatine nerve block, the second division nerve block, the anterior middle superior alveolar nerve block, and the palatal approach to the ASA. Maxillary infiltration is used to achieve pulpal anesthesia of one or two maxillary teeth. The area anesthetized is the pulp and the buccal soft tissue and bone of the tooth anesthetized. The recommended needle is a 27 gauge short. The insertion site is in the height of the mucobuccal fold over the apex of the anesthetized tooth. The needle is held parallel to the maxillary bone and inserted until the needle tip is at or above the apex of the tooth. After 2 negative aspirations, 1/3 of a cartridge of local anesthetic is slowly injected. The posterior superior alveolar nerve block provides pulpal anesthesia to the 3 maxillary molars and the supporting buccal soft tissue and bone. In 28% of patients, the mesial buccal root of the first molar may not be anesthetized. A 27 gauge short needle is recommended. For the left PSA nerve block, a right-handed operator should sit at the 10 o'clock position facing the patient. For the right PSA nerve block, a right-handed operator should sit at the 8 o'clock position facing the patient. The insertion site is the height of the buccal fold adjacent to the maxillary second molar. The syringe is held in an upwards, inwards, and backwards direction and is inserted to a depth of 16 millimeters. After 2 negative aspirations, a half a cartridge of local anesthetic is administered over 30 seconds. The middle superior alveolar nerve block provides pulpal anesthesia to the maxillary premolars and the mesial buccal root of the maxillary first molar. A 27 gauge short needle is recommended. For the left MSA nerve block, the right-handed operator should face the patient directly from the 8 or 9 o'clock position. For the right MSA nerve block, a right-handed operator should face the patient from the 10 o'clock position. The insertion site is the height of the buccal fold adjacent to the maxillary second premolar. The needle is inserted until its tip is located well above the apex of the second premolar. After 2 negative aspirations, a half a cartridge of local anesthetic is slowly deposited. The anterior superior alveolar nerve block, also known as the infraorbital nerve block, provides pulpal anesthesia to the 5 maxillary anterior teeth, the incisors, the canine, and the 2 premolars, in addition to the buccal soft tissue and bone overlying these teeth. The skin of the lower eyelid, the lateral side of the nose, and the upper lip is also anesthetized. For a right or left ASA nerve block, the right-handed operator should sit at the 10 o'clock position facing in the same direction as the patient. The infraorbital foramen is palpated and the lip is retracted. A 25-gauge long needle is inserted into the height of the buccal fold adjacent to the maxillary first premolar. The needle is held parallel to the maxillary bone and inserted until bone is contacted at the roof of the infraorbital foramen. After 2 negative aspirations, 1/2 to 2/3 of a cartridge of local anesthetic is deposited over 30 to 40 seconds. The greater palatine nerve block, also known as the anterior palatine nerve block, provides anesthesia to the posterior portion of the hard palate and its overlying soft tissues, anteriorly as far as the first premolar and medially to the midline. A 27-gauge short needle is recommended. For the left greater palatine nerve block, the right-handed operator should sit facing in the same direction as the patient at the 11 o'clock position. For the right greater palatine nerve block, a right-handed operator should sit facing the patient at the 7 or 8 o'clock position. A cotton swab is placed in the patient's mouth to palpate the greater palatine foramen. The needle is inserted into the soft tissues just anterior to the greater palatine foramen. As the needle is advanced through soft tissue, local anesthetic is deposited. On contacting bone and following negative aspiration, 1/4 to 1/3 of a cartridge of local anesthetic is deposited over 15 to 20 seconds. The nasopalatine nerve block provides anesthesia to the anterior portion of the hard palate, both soft and hard tissues, from the mesial of the right first premolar to the mesial of the left first premolar. For the nasopalatine nerve block, sit at the 9 or 10 o'clock position, facing in the same direction as the patient. In the multiple injection technique, the first injection is an infiltration into the labial soft tissues between the 2 central incisors. 0.3 mL of anesthetic is administered. The second injection is an infiltration into the now numb papilla between the 2 central incisors. Local anesthetic is administered as the needle is advanced until blanching is noted on the palatal soft tissues. The third injection is a traditional nasopalatine nerve block in which a needle is inserted into the soft tissues just lateral to the incisive papilla. The needle is advanced through soft tissue until bone is contacted, and following negative aspiration, 0.3 mL of local anesthetic is administered. The maxillary or second division nerve block provides pulpal anesthesia to the maxillary teeth on that side, the buccal soft tissue and bone overlying these teeth, the soft tissues and bone of the hard palate and part of the soft palate medially to the midline, the skin of the lower eyelid, the side of the nose, the cheek, and the upper lip. A 25-gauge long needle is recommended. Following completion of the greater palatine nerve block, the needle is inserted into the soft tissues over the greater palatine foramen. The needle is inserted into the greater palatine foramen and advanced to a depth of 30 millimeters. Following negative aspiration, 1.8 mL of local anesthetic is deposited slowly over minimally 1 minute. The anterior middle superior alveolar nerve block provides pulpal anesthesia to the 5 maxillary anterior teeth, the incisors, canine, and premolars, the buccal soft tissue and bone, and the palatal soft tissue and bone overlying these same teeth. A 27-gauge short needle is recommended. For the AMSA nerve block, sit at the 9 or 10 o'clock position, facing in the same direction as the patient. The needle is inserted into the tissues at a point halfway along the line between the premolars and the midline of the palate. 1.4 to 1.8 mLs of anesthetic is slowly deposited. The palatal approach to the anterior superior alveolar nerve block, also called the PASA, provides pulpal anesthesia bilaterally to the maxillary incisors and to a lesser degree the maxillary canines, as well as the labial and palatal soft and hard tissues of these teeth. For the PASA nerve block, sit at the 9 or 10 o'clock position, facing in the same direction as the patient. A 27-gauge short needle is recommended. The needle is inserted into tissue lateral to the incisive papilla. The needle is inserted slowly to a depth of 6 to 10 millimeters into the incisive canal. Following negative aspiration, a volume of 1.4 to 1.8 mLs of local anesthetic is administered slowly. We will now discuss the following techniques which provide anesthesia to the mandibular teeth and their supporting soft and hard tissues. Inferior alveolar nerve block, buccal nerve block, the Gau-Gates mandibular nerve block, the Vazirani-Akinosi mandibular nerve block, the incisive nerve block, also known as the mental nerve block. The inferior alveolar nerve block provides anesthesia to the pulps of the 8 mandibular teeth in that quadrant, the buccal soft tissues and bone anterior to the mental foramen, the anterior 2/3 of the tongue and the floor of the mouth, and the lingual soft tissues and periosteum. A 25-gauge long needle is recommended. For a left inferior alveolar nerve block, the right-handed operator should sit at the 10 o'clock position, facing in the same direction as the patient. For the right inferior alveolar nerve block, the right-handed operator should sit at the 8 o'clock position, facing the patient. There are 3 criteria for determining the correct insertion site for the needle. The first is the height, the second is the anterior-posterior position, and the third is the depth of penetration. A finger is placed on the lingual aspect of the ramus and pulled anteriorly until the carotenoid notch is palpated. The carotenoid notch is the greatest concavity on the anterior border of the ramus. The barrel of the syringe is placed in the corner of the mouth on the opposite side. The needle tip touches the most posterior aspect of the pterygomandibular raphe. The needle tip is then moved half the distance toward the carotenoid notch and then half the distance back toward the raphe. This locates the injection site, which is 3/4 of the distance from the carotenoid notch to the raphe. The needle is then inserted and advanced slowly until bone is contacted. The average depth of penetration is between 20 and 25 millimeters, which is 2/3 to 3/4 the length of a long dental needle. Once bone is contacted, aspiration is performed twice, and if negative, 1.5 to 1.8 mLs of local anesthetic is administered slowly. The buccal nerve block provides anesthesia to the soft tissue and periosteum on the buccal aspect of the mandibular molars. The injection is given immediately following the inferior alveolar nerve block. A 25-gauge long needle is recommended. The needle is withdrawn, the syringe is repositioned, and the needle reinserted in a mucobuccal fold distal to the last mandibular molar. 0.3 mLs of anesthetic is administered. The Gau-Gates mandibular block provides pulpal anesthesia to the mandibular teeth the buccal soft tissue and bone, the anterior 2/3 of the tongue and the floor of the oral cavity, the lingual soft tissue and periosteum, as well as the skin of the zygoma, the posterior portion of the cheek, and the temporal regions. A 25 gauge long needle is recommended. For the left Gaugates mandibular nerve block, the right-handed operator should sit in a 10 o'clock position facing in the same direction as the patient. For a right Gaugates mandibular nerve block, the right-handed operator should sit in the 8 o'clock position facing the patient. The coronoid notch is palpated. The barrel of the syringe is placed in the corner of the mouth on the opposite side, and the needle tip is placed just below the mesiolingual cusp of the maxillary second molar. And then the needle tip is moved just distal to the second molar. This locates the insertion site for the Gaugates injection. The needle is now inserted until bone is contacted. The average depth of penetration in a Gaugates injection is approximately 25 millimeters. After negative aspiration, 1.8 mL of anesthetic is slowly administered. Following withdrawal of the syringe, the patient is asked to keep their mouth open for 2 minutes. The Vazirani-Akinosi closed-mouth mandibular nerve block provides anesthesia to the 8 mandibular teeth, the buccal soft tissue and bone anterior to the mental foramen, the anterior 2/3 of the tongue and the floor of the oral cavity, and the lingual soft tissues and periosteum. A 25 gauge long needle is recommended. For the right or left Vazirani-Akinosi nerve block, the right-handed operator should sit at the 8 o'clock position facing the patient. The needle is inserted into the soft tissue on the lingual aspect of the mandibular ramus, adjacent to the mucogingival junction of the last maxillary molar. With the bevel facing away from bone, the syringe is inserted 25 millimeters. Following negative aspiration, 1.5 to 1.8 mL of anesthetic is slowly injected and the syringe withdrawn. The incisive nerve block provides pulpal anesthesia to the 5 mandibular anterior teeth, the incisors, canine, and 2 premolars, the buccal soft tissue and bone anterior to the mental foramen, and the skin of the lower lip and the chin. A 27 gauge short needle is recommended. For the right or left incisive nerve block, the barrel of the syringe is kept below the patient's line of sight, and the needle inserted into the buccal fold adjacent to the first premolar, and then advanced until the needle tip lies outside the mental foramen. Following 2 negative aspirations, 1/3 of a cartridge of anesthetic is deposited over 20 seconds. The syringe is removed and pressure is applied extraorally or intraorally, forcing local anesthetic into the mental foramen, blocking the incisive nerve. What supplemental techniques are available to anesthetize the teeth, the soft and hard tissues of the oral cavity? Intraosseous techniques include the periodontal ligament injection, intraseptal injection, and intraosseous anesthesia. The periodontal ligament injection, or PDL, is also known as the intraligamentary injection. It provides pulpal anesthesia to a single tooth, its supporting soft tissues and bone. A 27 gauge short needle is recommended. Operator positions vary significantly with PDL injections on different teeth. Sit comfortably, have adequate visibility of the injection site, and maintain control over the needle. The bevel of the needle should face the root of the tooth. The needle is inserted interproximally into the gingival sulcus on the mesial and the distal of a 2-rooted tooth. To ensure success, there must be resistance to the administration of the drug and tissue ischemia at the site of the injection. A volume of 0.2 mL of local anesthetic is injected per root. The intraceptal injection is similar to the PDL. It provides pulpal anesthesia of one tooth, its supporting soft tissues and bone. A 27-gauge short needle is recommended. The needle is inserted into the center of the interdental papilla adjacent to the tooth being treated and is advanced until it enters the cancellous bone in this area. 0.2 of 1 ml of local anesthetic is administered. The intraosseous technique is used to provide anesthesia of one tooth, usually a mandibular molar when other techniques have failed. Local anesthetic is infiltrated into the alveolar soft tissue just distal to the tooth to be treated. Using a slow-speed burr, a hole is made through the cortical plate of bone of the mandible. A 27-gauge short needle is inserted into the bone, and local anesthetic is administered slowly, providing profound pulpal anesthesia of the tooth. There are 2 computer-controlled local anesthetic delivery systems currently available in North America: Compudent, also known as the Wand, and the Comfort Control Syringe System. Computer-controlled local anesthetic delivery systems enable the operator to deliver local anesthetic painlessly anywhere in the oral cavity, especially on the palate. The Compudent wand delivers anesthesia at 2 rates, slow and slower. At the slowest rate, a full cartridge is administered in 4 minutes. This rate is used in palatal injections, intraosseous injections, and the PDL. The faster rate deposits a full cartridge over 60 seconds and is used for other anesthetic techniques. The comfort-controlled syringe system has specific pre-programmed injection rates for 5 specific techniques. Both the Compudent wand and the comfort control syringe system have the ability to aspirate via simple controls. What are the special considerations for pain control in the various dental specialties? In endodontics, the prime considerations are the presence of inflammation and infection, and a consideration for post-operative pain control. Inflammation and infection have a negative effect on both the duration and the depth of local anesthesia. The use of intraosseous anesthesia and the introduction of articaine have helped to solve this problem. In regards to post-operative pain control, the administration of bupivacaine at the conclusion of endodontic treatment helps to keep the patient comfortable in the post-operative period. In pediatric dentistry, the prime consideration when administering local anesthesia is the increased risk of overdose, especially when treating the young, lighter weight patient. The following factors act to increase the risk of local anesthetic overdose in younger patients. A treatment plan including all 4 quadrants under local anesthesia in one visit. The anesthetic administered is a plain drug. No epinephrine is included. Full cartridges, 1.8 mL, are administered with each injection. The anesthetic is administered to all 4 quadrants at one time and exceeding the maximum dosage based on the patient's body weight. A second consideration in pediatric dentistry are the complications of local anesthesia. Soft tissue injury is more likely to occur in younger patients. This may be minimized by the use of a shorter-acting local anesthetic if it is indicated by the minimum depth and duration of the dental procedure. Warning the patient and their parent or guardian about the possibility of soft tissue injury if the patient bites, sucks, or chews on their lip or cheek while they are still numb, or a cotton roll may be placed between the patient's teeth and their lip, secured with dental floss to prevent injury. A third consideration in pediatric dentistry is technique. All local anesthetic techniques may be used in children, however, the following must be noted. The volume of local anesthetic must be minimized in younger patients. As a general rule, administer only half the volume recommended for adult patients for each technique. When anesthetizing the mandibular primary dentition, infiltration anesthesia will work, because the cortical plate of bone in children is not very thick and diffusion of the anesthetic drug will occur. Once the dentition becomes mixed, the cortical plate of bone in the mandible may be too thick and mandibular infiltration should not be attempted. The mental foramen is found between the two primary molars. The incisive nerve block may be administered to achieve anesthesia of the primary incisors, canine, and first molar using 1/4 of a cartridge of anesthetic solution. A consideration in oral surgery, periodontics, and dental hygiene is the need for hemostasis. To provide a clean surgical site and to minimize bleeding during surgery, epinephrine is injected by infiltration into the surgical site. A 1 to 100,000 concentration may be used even though there is a slightly greater hemostatic effect with 1 to 50,000 epinephrine. Inject only enough local anesthetic with epinephrine into the site to produce visible whitening or ischemia of the soft tissues. Another consideration is post-surgical pain control. The administration of bupivacaine at the conclusion of treatment helps in keeping the patient comfortable following surgical procedures. What are the localized complications associated with the administration of local anesthetics? The most common complications are needle breakage, paresthesia, facial nerve paralysis, and trismus. Needle breakage may be prevented by never inserting a needle into the soft tissue all the way to its hub, unless it is absolutely necessary for the success of the injection, and by not using 30-gauge needles. The most common cause of paresthesia is surgical trauma to the nerve due to hemorrhage, edema, or direct surgical insult to the nerve. In the absence of surgery, paresthesia may result from direct needle contact, hemorrhage, or the actions of the local anesthetic drug. Though precise figures don't exist, 4% anesthetics have a higher incidence of paresthesia than the lower concentration drugs. Most paresthesia occurs in the mandible, involving either the lingual or the mental nerves. Most paresthesia is transient, lasting from days to weeks and in some cases months. On rare occasion, a degree of paresthesia may become permanent. There is no definitive management available for paresthesia. Facial nerve paralysis occurs when you deposit local anesthetic into the body of the parotid gland, blocking the 7th cranial nerve, a motor nerve to the muscles of facial expression. This most often occurs following the inferior alveolar or the Vazirani-Akinosi mandibular nerve blocks. It may be prevented in the inferior alveolar nerve block by contacting bone prior to depositing the local anesthetic solution. The motor paralysis lasts for the duration of soft tissue anesthesia of the administered local anesthetic. Trismus is a spasm of the muscles of mastication. It has many causes, but it usually occurs following the administration of multiple inferior alveolar nerve blocks on one side of the mouth in one dental visit. When the local anesthetic effect resolves hours later and the patient sleeps, the injured muscles go into spasm, leaving the patient unable to open or with severely limited opening in the morning. Trismus resolves over a period of days without treatment. If dental care is needed during this time, the Vazirani-Akinosi mandibular block can provide both pulpal anesthesia of the mandibular teeth and motor blockade to the muscles of mastication, thus allowing the patient to open their mouth. What are the systemic complications associated with the administration of local anesthetics? Overdose and allergy are the two recognized systemic adverse drug reactions that can occur with all drug administration. True documented and reproducible allergy to the ester-type local anesthetics can and does occur. True documented and reproducible allergy to the amide local anesthetics, in the opinion of many, including myself, has never occurred, or if it has, is so extremely rare as to be non-existent. Alleged allergy to epinephrine has been reported. However, you cannot be alive and be allergic to epinephrine. How do you handle the patient who has alleged allergy to either local anesthetic or epinephrine? First, believe the patient. and do not administer any local anesthetic or epinephrine until the alleged allergy can be disproved or proved to the patient's satisfaction. Ask the patient the following questions. Describe the allergic reaction. What was done to treat the reaction? What is the name, address, and telephone number of the doctor whose office in which the reaction occurred? The other systemic drug reaction is overdose. As the local anesthetic blood level increases in the central nervous system, clinical signs and symptoms of overdose develop. Severe overdose causes tonic-clonic seizures, usually lasting for 15 to 30 seconds, after which time the anesthetic blood level falls below the seizure threshold. Management of a local anesthetic-induced seizure is based on the PABCD protocol for all medical emergencies. Position the victim supine, maintain the airway, assess breathing, assess circulation, and activate emergency medical services. Airway, breathing, and circulation need not be done during the seizure. However, once the seizure is over, these steps need to be reassessed and implemented as needed. Overdose should be prevented. Do not exceed the maximum recommended dose for a local anesthetic drug. Do not administer full cartridges for every injection. Use local anesthetics with epinephrine whenever treatment includes 2 or more quadrants in one visit, especially in children. Always aspirate at least twice prior to giving a local anesthetic injection. Always inject slowly. Observe the patient in the 5 to 10 minutes following local anesthetic administration, the time during which most adverse drug reactions occur. Maintain your ability to administer basic life support.